the primary prevention intervention in the Head Start centers, primarily Head Start centers, as well as other ECE centers in the intervention catchment areas in Houston and Austin. And then we've also sampled ECE centers in the comparison catchment areas as our control group. We implemented the Catch Early Childhood program, and I'll talk about that in a minute about the various components. But it essentially uses a train the trainer model. So we trained the ECE centers in implementing the programs. We trained the teaching staff and the center directors. And we held a training as well as several booster sessions at the centers across the 2-year implementation period. The centers got various kinds of materials related to the program, but we also developed a coordination guide as part of Texas CORD to facilitate the environmental component with regards to healthy eating and physical activity across the different classrooms in the center. And finally, we had a lot of technical support and ongoing support that we provided to the sites throughout the implementation period, just to monitor implementation, provide resources, to brainstorm, troubleshoot, and as well as conduct retraining in case of teacher turnover. As I mentioned earlier, this was a quasi-experimental study. So we had Head Start and other ECE centers in the intervention catchment area. And similarly, we sampled centers in the comparison catchment areas in both Houston and Austin. Our main outcome was to look at impact on child BMI. So we looked at child BMI percentiles and Z-scores, and we measured them across 2 years. So our baseline was in spring 2012, and our follow-up was in spring 2014. And then we also conducted parent surveys just to get the impact on child behaviors related to diet, physical activity, sleep, and so on. And we conducted those surveys at 3 time points over the 2 years. And then we used mixed effects linear regression analysis to look at the impact of Catch Early Childhood intervention in our sample. Next slide, please. So I wanted to spend a couple of minutes just talking about our program, and the whole purpose of the Catch Early Childhood program is to elevate the preschool environment and to link the preschool with the home. And so we have classroom lessons that are fun, interactive, focus on healthy nutrition, as well as it has a gardening component to essentially create excitement around nutrition and even physical activity in the children. We also have, you can see a small purple physical activity box in the picture there that has over 500 developed age and developmentally appropriate physical activities. It even has a component to engage children with disabilities. And finally, there's a parent engagement piece, which links the information that's taught in the school with the home through newsletters and tip sheets in both English and Spanish that went home to the parents. And then across the three, the kind of the cross-cutting tool that we developed, as I mentioned earlier, was the coordination kit, which essentially created opportunities for the children to practice healthy eating and physical activity at preschool, and then also carry that information into the home. Next slide. This is a little snapshot of the various activities that we had. The motto of Catch is, if it ain't fun, it don't get done. So the premise of all the materials was that we have to make it fun and easy to implement within the preschool setting. So here you see a sample lesson plan that focused on healthy eating more vegetables, and we had the catch go slow whoa language embedded in it to talk about everyday sometimes foods. We had the, you see the snack to health, which was a tip sheet that went home to the parents to help them plan the meals and recipe development and just easy tips and tools on how to prepare healthy snack. And the bottom picture is about is an example of a bulletin board through the coordination kit that the kids developed and worked on. Next slide. So the main outcomes, that's what we're getting into, but this is a picture of the catch MVP part that's implemented as part of the coordination kit, and you see the t-shirts that the kids actually made and are wearing right there. So that this was another example of the coordination that happened across the preschool. Next slide. So at baseline, our families were primarily Hispanic and had an annual household income of less than $25,000, about 81% of them, and 84% were on Medicaid or Texas Health Steps. Also, our sample, the overweight obesity prevalence was quite high. About 36% of our kiddos ages 3 to 5 were overweight or obese, and this was a sample of 685 kids. Next slide. So looking at our main outcome, so we wanted to look at BMI Z-scores and BMI percentiles. And essentially, what you have here is the group by time interaction. So we looked at change in the slopes for the BMI Z-scores in the intervention as well as the comparison group. And the intervention is in the red and the comparison is in the blue. And so we had a significant decrease in the BMI Z-scores among children in the intervention group as compared to those in the comparison group where the BMI Z-score actually went up. Next slide. And similarly, with the BMI percentiles, we saw a significant decrease in the BMI percentiles among those in the intervention group as compared to those in the comparison group. And this adjusts for all baseline differences as well as several other covariates. Next slide. So this is a quick snapshot of within group changes as well as between group changes. So the first set of columns are the intervention, and then we have the comparison group. And you can see that baseline to post-test, there were differences, within group differences, where the BMI Z and the percentile actually went down, whereas the comparison group, it concurrently went up. Next slide. We also looked to see if there were any changes in some of the behavioral metrics with child fruit intake. There was a trend while the comparison group remained flat. The intervention group went up. However, these differences were not statistically significant. Next slide. And similarly, for vegetable intake, there was a slight increase in the child vegetable intake among those in the intervention group as compared to the comparison group kids, but this difference was not significant as well. Next slide. With eating out, we saw that the kids in the intervention group stayed flat, whereas those in the comparison group seems to go up with the frequency of eating out. Again, these differences were not statistically significant or approach significance, but were not there yet. Next slide. And this was with intake of French fries. You see a similar trend where the intake of French fries went up more so in the intervention, in the comparison group as compared to those in the intervention group. But again, the results were not significant. Next slide. We also monitored over the 2 years, we monitored implementation of the program. And so we developed an implementation index to look at the extent of implementation of Catch Early Childhood, as well as other health-related activities across our intervention and comparison centers. So we monitored this not just because Catch Early Childhood was available for purchase nationwide, but when we started CORD, we wanted to see, well, are other centers implementing the program as well, or other programs that might be related to nutrition and activity. And we saw, what you see here is the Catch Implementation Index, Catch II in year 1, year 2, and overall implementation indices, which include Catch as well as other health events. And what was encouraging is that if you look at the high implementation bar, you can see that those in the intervention centers had high implementation of the Catch Early Childhood program, and comparison centers, you would expect them, as expected, they had low implementation. But interestingly, there were some centers in the comparison catchment area that were trained way back and were implementing Catch Early Childhood from before CORD that were in the project as well. So, so I think this gave us a really nice picture of what's happening across the 2 catchment areas with regards to Catch implementation. Next slide. We also computed the cost per participant as part of that AIM 3, and the first 2 programs are the primary prevention programs, and MEND, Next Steps was also primary prevention in the healthcare setting, and MEND was the secondary prevention program. And you can see that the cost per participant for Catch Early Childhood was about $26. And as compared to some of the other programs, which was Catch Early Elementary was the lowest and MEND was the highest. Next slide. So to kind of summarize, we had significant changes in child BMI-Z and percentiles following 2 years of implementation. We did see some trends with regards to increase in fruit intake and perhaps a substitution behavior, decrease in French fry and eating out, but there were no other changes with regards to behaviors or differences by racial ethnic group. We were very encouraged that there was high implementation of the program in the intervention centers, and also interestingly, there was some implementation in the comparison centers, which may explain why the BMI at baseline for the comparison centers was lower than that in the intervention centers, because some of them were implementing Catch Early Childhood for years before that. So, the program was fun and easy to implement for the preschool teachers, and adoption was high. Next slide. So I thank you again for the opportunity, and I'll turn it back to you, Deanna.
Thanks, Dr. Sharma. Now we'd like to turn to California CORD, and Shifan, our Sam Lin, will be presenting about their early care and education intervention.
Good morning or good afternoon, everyone, depending on where you are. So today I am going to present you with our early care and education intervention and the C8 CORD study. Next slide, please. So our university partnered with 2 community agencies. We have a federally qualified health center, Clínicas de Salud del Pueblo, as well as the Imperial County Public Health Department to implement our interventions. And all of our interventions were implemented in the Imperial County, where there is a large Hispanic population with childhood obesity rate at 40%. This is why that we specifically target this geographic area. Next slide, please. So our objective is to use a whole community approach to prevent and control obesity. So we targeted several community sectors in our interventions, but for today we're going to focus on the EC interventions, and therefore we're targeting children's age between 2 to 5. In addition, we also targeted 4 child behavior throughout our interventions, and these are water drinking, healthy eating, physical activities, and sleep. Next slide. So public health intervention is one of the 4 arms of interventions in our studies. And as I mentioned earlier, we targeted several community sectors. These include EC centers, schools, and community recreation organizations. Throughout our interventions, we focus on 4 primary strategies. These are capacity building, physical environment change, system policy change, and communications. And throughout our next few slides, I will go through all of these intervention components. Next slide, please. So as I mentioned earlier, our ECE interventions are targeted 14 agency-based centers, and there are 4 affiliated agencies. And all these agency-based centers are government-funded programs such as Head Start, Early Head Start, or Migrant Head Start. We also have 9 private centers. These are all private or faith-based centers. Both types has very similar characteristics. You can see our characteristics display here. In addition, we found that more private centers offer both full and half-day cares than the agency-based centers. And also, more importantly, more private centers than the agency-based center had no previous physical activity trainings before we intervened. Next slide, please. So now we're ready to look at each of the individual intervention component. In addition to showing you what we did, I also want to present you how well we implement each of the interventions. So for the results, I will be showing you the fidelity between the 2 types of centers, and the fidelity will be defined as the percentage of dose received over planned dose. So I believe most of you are very familiar with the knapsack. So knapsack is an evidence-based approach to assess and plan for policy, practice, and environmental changes in the ECE centers. So for this component, we actually have the initial and final assessments of what changes need to be done and whether these changes were made. And then for the 4 collaborative meetings, we have it over a period of 9 months. So in these meetings, we plan for our actions, and in the follow-up meetings, we assess how far along are we on the plan. And then we also provided technical assistance throughout the 9 months period to assist with the center. So for our implementation results, all these centers had received their initial and final assessments. For the collaborative meetings, 2 of the private center actually did not receive the final follow-up meetings because they were closed for a prolonged period of time at the time we were conducting the meetings. That's why you will see that there were some of the center received only 75% fidelity in the orange text here. Next slide, please. So our next intervention component is physical activity trainings, and for this training we use the SPARKT curriculum. It is an evidence-based program that offers strategies to increase the quantity and quality of developmentally appropriate physical activities in the centers. So we offer a 6 hours long physical activity trainings, and we require 1 agency staff and all the center staff to attend the trainings. In addition, we also offer a $25 gift card to the center if they attend the trainings. So in addition, we provided on average of 2 SPARKT kits and physical activity equipment value at $400 to all the centers to supplement what they're learning from the training, so they can make use of these materials along with what they're learning from the training to implement this into their physical activity lessons in the center. So in terms of implementation results for SPARKT training attendance, we see that private center actually had a better fidelity compared to the agency-based center, 60% versus 32.9%. For our gift card incentive, almost all the centers who attend the training received the incentive, except there were few centers that attended the training but not at their scheduled time. Therefore, you're seeing that there's some 0% fidelity there in the orange text. Finally, for our SPARKT kits, all the center receive our SPARKT kit. Next slide, please. So for our health behavior trainings, it's actually a lecture-based training to focus on childhood obesity preventions, and we targeted 4 areas of childhood obesity, including healthy lifestyles, BMI, mindful eatings, and physical activities. So we provided 3 different trainings to each center, and each of the training lasts about an hour and a half. We require at least 1 staff to attend all 3 of the health behavior trainings. Similar to the SPARKT training, we also provide a $25 gift card to the center if they attend each of the trainings. So in other words, if a center attended all 3 trainings, they are receiving a $75 worth of gift card. So for our results for implementations, in terms of attendance to 3 health behavior trainings, you'll see that these trainings are very well attended between both types, and you will even see that there are some centers that had fidelity rate over 100%. This just means that there were more than 1 person in their center attended 3 health behaviors. So in the orange text, you'll see that there are 200% fidelity, meaning that 2 of the staff actually attended all 3 meetings. While you're looking at the green text there were some centers that had 0% fidelity. It's just because that the center did not attend the training, or they attended 1 or 2 trainings but not all 3, so we consider them as 0% fidelity. For our gift card incentive, all the centers who attended the training received the incentive, except few centers who did not attend the training at their scheduled times, so we did not give that incentive to them. Next slide. Our next component is the health behavior toolkit. Each center received this toolkit with 3 sets of educational materials and resources to help promote the 4 target behaviors, and you can see on the right hand side these are our toolkits. These materials were separated into different tabs so they can retrieve this information quickly. In terms of our implementations, all the centers receive the toolkits that we provided. Next slide. So for our cooking kit and water access, each center was provided with 1 cooking kit, and this cooking kit contains child-friendly cooking and serving items that allow children to be engaged in cooking activities and practice serving the healthy family-style meals. And if you look at the pictures on the right-hand side, these cooking items are child-friendly, and so there are wooden spoons and other cooking cooking utensils. So in terms of water access, each center also was provided with a water dispenser so that it can provide child with greater access to water. So in terms of our implementation modalities, all the centers received a cooking kit as well as a water dispenser to be used. Next slide, please. So for our media and messaging components, we do create posters So this is two versions of the poster for each of our 4 health behaviors that we targeted. So if you look at the picture on the right-hand side, these posters are displaying children from our community that were engaging in these healthy behaviors. All of the centers received the numbers of posters that they requested. So you'll see that there are 100% fidelity for both agency-based and private center. Next slide. For our BMI, we have 3 mini components within this larger component. So for BMI assessments, we measure height and weight for all the children in the ECE centers. We plan to measure all of them, but in reality, we weren't able to measure all of them. For BMI cards, for the children who were assessed for height and weights, we actually give a BMI card for their parents or caregivers. So these BMI cards are very similar to the immunization card, whereas parents can enter child's BMI at each subsequent visits to the doctor, and these include wellness checks or their immunization checks to the doctors. Finally, we also provided a 2-hour-long BMI trainings to only agency-based centers and the agencies. All these center staffs and agency staffs were expected to attend the trainings. So in terms of our implementation results, you'll see that for children's BMI assessments, agency-based centers had higher fidelities compared to the private centers. So you'll see that there's 74% versus only 41%. In terms of the BMI cards given to the caregivers, all the caregivers actually receive the BMI cards for those children who were assessed for BMI. And finally, for our BMI training attendance, you'll see that for the agency, they actually have a super large fidelity rate there, and it's actually not a typo. The reason for this is because the agency had opened up the training to all the staff in the agencies, rather than our plan was that we are only providing trainings to the staff who is providing direct care to the children. That's why we're seeing that there is a large fidelity percentage there. For the agency-based centers, you'll see that in the green text, the median fidelity is 0%. However, it doesn't mean that none of the center received the BMI training. It's because there are many centers opted not to attend this BMI training, and therefore it is biasing our median at 0%. So if you look at the mean fidelity for the BMI training, it's actually 54.3%. You'll see that in the asterisks there. So this is considered relatively low fidelity compared to other components that we implemented. Next slide. So this is the BMI card that we give out to our caregivers, where in these boxes, the caregivers can write down day of the measurements and their BMI. Next slide, please. So we also have some BMI assessment results. I want to remind you, these are not the results from our cohort, because we do have a cohort that we follow separately. So these BMI assessment results are cross-sectionals across all the centers. So we do have some preliminary results to show you for children who were measured after 1 year of intervention. So it looks like for the agency-based centers, boys have a higher prevalence of obesity compared to girls. However, in the private centers, boys have a lower obesity prevalence. And we also provided the national prevalence there for you to see as a reference. Next slide. For among 7 agency-based centers only, we have the baseline data. So in this slide, we can see that for girls, there seems to be an increase in obesity prevalence, whereas for boys, we have a very slight decrease in obesity prevalence. And I want to remind you, this is only for the selected 7 agency-based centers that we have. Next slide. In terms of our intervention, in addition to our intervention components, we also kept number of hours of contacts for the 2 types of centers. So in this slide, you can clearly see that agency-based centers have a lot more contact hours compared to the private center, and that's partly because the agency-based center received additional BMI trainings that the private center doesn't have. And also we have this extra sustainability phase that wasn't planned. What happened was that after the intervention ended, agency-based centers actually request us to have more interaction with them. So we actually had provided more resources to them, and we have more checking in with them, and then we did a little bit more of the action planning and goal setting with them. In terms of the color, you will see that most of these contacts were in blue because these are in-person contact versus those in orange. There were other contacts that are in emails or in telephone calls. Next slide. For our agencies, we also have some contact hours. Again, these are mostly in-person rather than other contacts. Remember that these agencies have some contact hours because they also receive the BMI training. And most importantly, because we implemented the interventions with the agency-based centers, therefore there's additional layers of management and administration that we need to go through with the agencies before we can conduct interventions at the agency-based centers. Therefore, there are some, hours that goes to the agencies. Next slide. So finally, lesson learned. For our knapsack, it was implemented with good fidelity. Most importantly, we feel the substantial technical assistance provided by the consultant was quintessential to the success of knapsack, and this was actually proven from other research as well, that substantial technical assistance was the best thing that was provided in the knapsack components. We also found that private center had greater fidelity for SPARKT training. It's possibly due to the lack of prior physical activity trainings for the private center staff, as we've seen in the characteristic slides, that these private center staff does not have much physical activity training prior to our intervention. We also found that fidelity for health behavior training was higher than SPARKT training. It's probably because SPARKT training was too long. It was 6 hours, and they're usually scheduled on Saturdays. So for future implementer, we actually recommended to spread out our SPARKT training into multiple sessions and to schedule them on weekdays. Also, we found that there's more time and labor needed with the agency-based centers. As I mentioned earlier, there's additional layers of administrations and management that we need to go through in order to implement the interventions in our agency-based centers. Finally, we found that documenting the contact is valuable, including the durations, because for practitioners who want to replicate our interventions, it is helpful for them to look at these duration of contact so they have an idea of how much time they need to invest in our interventions. Next slide. Finally, I would like to acknowledge our funder, CDC, and I would like to thank all of our investigators and key staff in our team. Thank you. Now I'll turn to the next speaker.
Thanks, Dr. Lin. And now we're going to change and talk a little bit about WIC. So Dr. Jennifer Wu Bidell will present from Massachusetts Early Care and Education Initiative.
Hi, so I think it auto-advanced the slide. My name is Jennifer Wu Bidell, and thank you for giving me the chance to present outcomes from the MACORD Early Childhood Intervention in WIC. Next slide. So the Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC, is a far-reaching federal nutrition program annually serving around 4 million children under age 5 years. Pregnant and postpartum women, infants, and children in households with income at or below 185% of the federal poverty level are eligible for benefits that include nutrition assessment and counseling and a food package. And given WIC's broad reach, and as we heard earlier, the higher prevalence of childhood obesity in this low-income population, it is well positioned as a platform to prevent childhood obesity early in life, yet few multi-sector interventions have incorporated WIC. Next slide. So the goal of this project was to implement and examine the effectiveness of MACORD intervention components delivered through WIC to reduce obesity risk factors in children aged 2 to 4 years versus those in the comparison community over 2 years. And we hypothesized that children in the 2 MACORD intervention sites would have slower rates of increase in BMI Z-score and greater increases in prevalence of target behaviors that are known to help prevent obesity. Next slide. So in MACORD 1.0, we had a great collaboration between the Massachusetts Department of Public Health, the Harvard School of Public Health, and Mass General Hospital for Children to evaluate a multi-sector, multi-level approach to obesity prevention. So this map shows the state of Massachusetts with the stars representing the MACORD communities. 2 MACORD intervention sites and 1 comparison site were selected based on income matching, and all 3 sites were low-income communities with a high proportion of childhood overweight and obesity, with prevalence around 30% in each site. They also were part of the existing Mass in Motion initiative that's led by the Massachusetts Department of Public Health, which means they all had an existing infrastructure to support community-level activities and coordination. Next slide. The chronic care model and energy gap model form the overarching frameworks for the MACORD intervention development. And as the orange table illustrates, multi-level interventions in multiple sectors, including the community, primary care, WIC, school, after-school, and child care sectors, were implemented through an integrated approach. The implementation and evaluation in the other sectors is covered in other webinars, and some of the main study results were published in Obesity in July of this year, 2017. So to focus on WIC, as all of the sectors had similar target behaviors that focused on healthy beverage, food, screen, physical activity, and sleep behaviors. But to focus on WIC, as outlined in the blue box, practice change initiatives really formed the basis of the intervention. And prior interventions that were shown to be efficacious using motivational interviewing and systems changes, such as the High Five for Kids intervention led by Elsie Taveras, formed the basis of the intervention components in WIC. Because MACORD was led by the Massachusetts State Department of Public Health, this facilitated our partnership with state and local WIC stakeholders to perform a needs assessment and develop tailored interventions at multiple different levels, as outlined in the blue chart. So at the community level, WIC providers were linked with other sectors and local initiatives, including participation in an obesity learning collaborative led by NICHQ. And at the system level, we implemented a full day with provider training on early childhood obesity assessment and counseling that all WIC providers and MACORD WIC sites attended. We also, based on feedback from our needs assessment, developed and implemented a Train the Trainer program that focused on healthy screen and sleep behaviors and developed tailored toolkits. At the individual level, the newly trained WIC providers were able to perform kind of enhanced assessments and counseling to deliver motivational interviewing-based counseling using health messages that were similar to those from the other MACORD sectors. And they were also able to provide streamlined referral to the healthy weight clinics in each community. So the goal was for the WIC participants to receive assessment, coaching, and coordinated support by the WIC providers and providers spanning other sectors, such as community health workers. Next slide. This is just a sample of some of the materials, including a weight room poster, coloring book, and other materials. Next slide. So to evaluate the project, we collected longitudinal BMI data from all 2 to 4-year-olds of any BMI category who had a qualifying WIC visit using the electronic WIC record in the 2 MACORD intervention communities and the comparison site from 2010 through 2015. And the intervention start date was September 1, 2012. Those who had at least one visit during the pre-intervention and one during the post-intervention time point were included. And in addition to the longitudinal cohort, we extracted serial cross-sectional survey data on our target behaviors at baseline and at the year 2 time point. Next slide. So using similar quasi-experimental methods to evaluate the results, we use multivariable, multi-level mixed effects models to examine the difference in BMI Z-score change per year for the intervention sites compared to the comparison. And we also use logistic regression models to examine changes in prevalence of the target behaviors. And models were adjusted for child age, sex, and race ethnicity. Next slide. So you can see in the longitudinal BMI cohort, we had 198 children from MACORD Site 1, 637 from Site 2, and 626 in the comparison site. And mean child age was a little over 2 years at baseline, and about half were male. In MACORD 1, WIC participants were more likely to have white race, and in the comparison site, more children were of Asian background. Next slide. So we found for the BMI Z-score results that children in MACORD intervention sites had decreased BMI change over time versus the comparison during the post-intervention period, but these findings were not statistically significant for either site. However, because there was an imbalance in the number of children with Asian ancestry across sites, and Asian children tended to have lower baseline BMI Z-scores, we additionally performed analyses excluding Asian children. And in these models, we found that children in Site 2 had a small but statistically significant decline in BMI Z-score of 0.08 units per year. Next slide. In the separate sample of children with serial cross-sectional behavior data, here you can see the y-axis represents the adjusted odds ratio of increased prevalence of target behaviors from the pre to post-intervention time period compared to the comparison. And we found statistically significant greater odds of increased prevalence of avoidance of sugar-sweetened beverages in both communities, limitation of juice intake in Site 2, and meeting age-appropriate sleep recommendations in both sites. Next slide. So to summarize, non-Asian children in Site 2 had a decline in BMI Z-score. In Site 1, we did not find a statistically significant difference in BMI Z-score over time. And we also found that the prevalence of obesity risk factors improved in both sites, including increased prevalence of sugar-sweetened beverage avoidance and increased prevalence of sleep sufficiency. So I think the strength of this work was the implementation in many sectors and levels with a comparison site, overall large sample size, use of longitudinal data, and use of systems level interventions that enhance the ability to scale up. But one of our limitations was a smaller sample size in Site 1 that might have limited our ability to find statistically significant differences in BMI Z-score over time. Next slide. But I think overall we show that this multi-sector, multi-level approach did improve obesity risk factors among 2 to 4-year-olds enrolled in WIC in low-income communities. Next slide. And I would just really like to acknowledge this joint effort through the NA Department of Public Health, Mass General Hospital for Children, Harvard School of Public Health, and particularly thank the MACORD WIC site participants and study team for making this project a success, as well as acknowledge the main funding source. Thank you.
Thank you very much. Now we're right at time, but we can go over a few more minutes if anyone wants to hang on, and we'll answer a few questions. I know one of the questions, Dr. Wu, Bidell, and Dr. Lin, it seems like across the board, people have asked, are these materials available? So they're referencing the Our Choice posters and some of the materials used in Massachusetts CORD. So Jennifer or Sam, can y'all maybe answer that question? Jennifer, if you want to go first.
Sure, yes. Yeah, sure. So I think they can contact me directly. I don't think that there's an automated way to order materials at this time, but I'm happy to have people email me about that, and I can help facilitate figuring out what materials they might be interested in that we can make available to them.
And your publication is out, so we can link to that in the notes, right?
Great. That would, yes, that the publication was in obesity this past July.
Yeah, so we can link to that article or put that citation in as well so that people can see that as a reference. Sam, are the posters available for people to use?
We don't have the actual posters, but if you can contact me, we definitely have the PDFs and all that. But I'm also working on my manuscript, so that should be out soon.
Great, thank you very much. I will tell you that the catch coordination guide is available too, so we'll put the link on the website. We also will have the slides up, so there's a link for where that is, and we can send it to everyone who's attended the website as well. So a couple of other questions that we had. One, in California, were people resistant to the BMI evaluation, the cards coming home? Dr. Lin?
We don't have that sort of experience that, I think the caregivers were willing to receive those and use them.
Great. So you didn't really have resistance from the parents then?
Not really, because they usually just put it together along with their immunization card. But to the extent of how well they recorded the information, that part we don't know.
Okay, thank you. Dr. Wu Bidell, there's a question about BMI in this age group. Is it a valid measure? Could you maybe answer that?
Yeah, so we, all the children were 2 or older. So we did, follow the kind of BMI guidelines for that age group. We, in this data I presented to you, are showing the Z-scores, which are age-adjusted, sex-specific measures for BMI.
Great. Thank you. So there's a question for all of the studies, and it's basically saying, are there any analyses that will be done that might look at aspects of the program that seem to have the most impact? I know here we're looking at a few, particularly looking at the implementation in Texas, looking at the implementation and how that was associated with outcomes. I don't know, maybe starting with Dr. Wu Bidell, are y'all planning any further analyses that way?
So we do have a group that is looking at overall process measures for MACORD, and that will, hopefully help shed some light as to what different aspects. But I think, in the kind of WIC sector in MACORD, we really worked directly with the WIC providers, and I think having had the Department of Public Health as the lead for the study really facilitated our ability to get kind of 100% buy-in with the WIC providers, who they probably taught me more than I would have ever imagined. They were very enthusiastic and already well-trained group of people.
That's actually really encouraging. I think WIC is a perfect place for intervention in this age group.
Yep.
Okay, I think we ran a little bit long, but I just wanted to say thanks to all of you for attending today, and thank you to the speakers. They did a fantastic job of sharing their project findings. We do have 3 other webinars coming along. One next week will deal with the CORD project school interventions. We'll be talking about the secondary prevention interventions for webinar number 4, which will be in November. And in December, we'll talk about overall results of the CORD project. This recording will be archived on the Michael and Susan Dell Center.org website. So if you can go there, you will find the webinar and a PDF of the presentation slides. And then we will follow up with some of the materials that the participants ask about. So thank you very much, and we hope you have a good rest of the day. Take care.